Hi, everyone. I'm Nicole Althouse. I get the extreme pleasure to be the U.S. ambassador with my co-conspirator, John Werner. But we're going to talk about women's health today. We're diving. Okay, I got to make sure I have this right. We're going to dive a little deeper than we typically do. We're going to talk about pelvic health today. This is quite the busy slide, but there's a lot that we didn't put up on there. I call it the hidden epidemic because there are so many things happening with women's health in the pelvic health space. It's not just a collection of medical conditions. It's actually a map of challenges affecting millions of women worldwide, and many of them suffer in silence. So if we take a look, there's three different types of pelvic health issues. They're hormone-driven, infection-based, and actually the functionality of the pelvic floor itself. And they all intertwine together and cause other things that happen within the body, including infertility. We'll touch on that a little bit today as well. But let's talk about some of the facts that really pop out. Endometriosis affects 200 million women globally. And it takes 7 years on average, plus 3 doctors to get a diagnosis. That's crazy. And then over 70% of all women will develop fibroids by the age of 50. And what's even more alarming is women of color will have an earlier onset and more severe conditions. 25% of reproductive aged women have bacterial vaginosis, and 50% don't even know that they have it. And the other one that strikes me as compelling is that despite affecting 5 to 10% of reproductive aged women, 70% of PCOS, that's polycystic ovary syndrome, cases remain undetected worldwide. So these issues tell us that there's a profound, this is not just a one-off thing. This is actually a thing. This is something that just demonstrates a vast interconnected web of challenges that affect workplace productivity, that impacts quality of life and healthcare equity. Understanding these issues is vital as they affect our physical health and emotional well-being. So, enough of me talking. We have some great panelists here that are giving you a view from all sides of pelvic health. And I'd like each one to introduce themselves, and then we'll do a moderated session with some questions. I'll start with you, Irene.
Hello, how are you doing today? I know it's just after lunch, so I hope you're awake. My name is Irene Inge. I'm the Chief Science Officer at the Society for Women's Health Research. And at the Society, we are a national nonprofit based in Washington, D.C., that advances women's health through science, policy, and education. Our work focuses on conditions that either exclusively affect women, so that's the pelvic health space, pregnancy, menopause are some examples, or conditions that disproportionately or differently affect women. So that's pain and metabolism, Alzheimer's disease, which affects 2 times more women than men, or autoimmune conditions that are 80% diagnosed in women. So we have a whole span, and here today talking about pelvic health, we have some focus in endometriosis, PCOS, as Nicole mentioned, as well as uterine fibroids are some major issues that affect women. And there is a lot that goes into this from the research side and not really understanding what goes on as far as exposures, as far as the genetic markers for some of these conditions, as well as the healthcare challenges that women encounter from dismissal of symptoms or normalizing symptoms in your family and not recognizing and having the proper tools to diagnose these conditions among women. And so I guess we'll dive in a bit more about that later, but thank you for having me, and I'm looking forward to the conversation.
Awesome. Emily.
I'm Emily. Can you hear me? Okay. I'm Emily Stein, CEO of Primal Therapies. We're focused on biofilm control and also the modulation of the microbiome through metabolism, both in oral care and also in women's health.
And Mark?
Can you hear me? My name is Mark Amuzgar. I am the CEO and co-founder of March Health. We are an AI clinic, comprehensive AI clinic for women's underlying health conditions like endometriosis, PCOS, and premature delivery and others. We use early diagnosis, early screening, and post-diagnosis with continuous care. And what we are doing at March Health is really close to my heart because my loved ones are impacted by that as well. So, as a matter of fact, 1 in 6 individuals, based on WHO's 2023 report, are dealing with infertility, and 90% of infertility cases are because of late diagnosis of underlying health conditions, including endometriosis and PCOS and others. And there are easy solutions that we can do and implement to help millions and tens of millions of people in the US and all over the world. That's the mission that we have, and super excited to have a fun session here. Thank you.
You see why this is going to be fun. Okay. So let's start with Irene. What are the most pressing issues of women's pelvic health that require immediate investment and attention? I know Jill Biden has just announced an enormous amount of funding that touches on this. Can you share a little bit more of what you see in the future?
Yes, as far as a pressing need, diagnosis, we see diagnostic delays due to a lack of understanding as well as innovation, finding biomarkers. I think that investment is very important. Identifying various biomarkers for these conditions. Also, investing in the research that will look at the association between gynecologic health conditions and other chronic disease conditions. You find that endometriosis, an individual who has endometriosis may also have IBS, uterine fibroids. You might see, as you mentioned, infertility. There's PCOS or obesity, diabetes that are associated. These hormonal issues do not live in a vacuum or in isolation. And so addressing those research issues is very important. And I think that underlying understanding, and because there are a lot of hormone-based issues, exposure is another. Environmental exposures. 10 years ago, we would say, oh, there's not enough data for understanding that, or, it's inconclusive. But it's been 10 years. So at this point, we should have the data to be able to inform these conditions and these decisions that women have to make for their health. And so I would say, since we have not had that investment, we really need to step up and invest in those areas of research.
Do you think that, as far as this new Biden initiative, do you think it'll be a widespread on women's health, or will it be focused in narrow areas like breast cancer and other things?
I think, so when the White House signed the executive order, different federal agencies made commitments. So, for example, the National Institutes of Health committed to doing $200 million in 2025. That would be new funds, new projects, not necessarily new funds, but new projects dedicated to women's health, aside from what they currently have in their portfolio. I want to say most recently, the Department of Defense committed to $500 million. Earlier this year, ARPA-H had a commitment as well for the Sprint for women's health. And these are great opportunities. The challenge is, for example, pelvic health isn't as sexy as Alzheimer's disease or breast cancer or some of these other more popular conditions. And I want to say popular only from just understanding or hearing about it in the media. And so there's always still that challenge that, where will the funds actually go? Because we have, in peer review systems, we have a natural bias to things that we're more familiar with, we want to fund. Things that are more popular in news and media, we want to fund. And we're not as familiar with the issues of PCOS. We're not as familiar with the issues of bacterial vaginosis, we're not as familiar with some of these other areas. And so that's where the awareness and the education comes into play. So I think is when we have sessions like this, hopefully you go back, you take it into the work that you're doing, whether it's on the industry side or healthcare side or the research, and it helps to build that awareness so that when the time comes to dedicate funds, do the peer review, that we're thinking about these other conditions as well.
Sorry, I kind of sprung that on you, but actually it's a great segue to Emily. So you're the scientist in the bunch.
Yep.
Yes. What advancements in understanding and treating of pelvic health conditions do you see
Yes.
now or in the future?
Right. So I just want to highlight the one of the considerations also with just tapping the NIH discussion and granting agencies is that if you're at the forefront of what we understand as far as the interplay between the microbiota and the host biology, really you are coming up with new findings, and that sometimes flies in the face of dogma. And so it becomes very difficult sometimes to actually get the funding that you really need to pursue these endeavors to really come up with the therapeutic or the preventative agent or truly identify and validate biomarkers in various different conditions, particularly in women's healthcare. So I just wanted to mention that as a struggle. But no, it's really exciting. Things that we're learning about evidence that suggests that up to 30% of the oral microbial compartment is driving various different gynecological conditions. 60% seem to be originating from the lower GI tract. We'll see how that plays out in future research, but we're definitely seeing through our work that by deploying different novel approaches, non-antibiotic and non-antiseptic approaches to really modulate what the microbes are doing in these various different compartments are having a profound effect on tissue health and wellness in women. So it's really exciting place to be, I think, for the next 10 to 15 years. Hopefully we'll see a lot coming into the market.
Great. And so let's talk on endometriosis. So Mark, you mentioned that, and I know your company focuses on the prevention or the detection of that. What strategies are employed today to help reduce the delay? Or at least what have you been working on as far as that goes?
Right now, it takes average of 7 to 10 years to get diagnosed with endometriosis. In order to address the question that you asked, let's deep dive into the reasons of the delay. Mostly, we are talking about gender biased. We have interviewed thousands of patients, endometriosis diagnosed patients. You go to a doctor, you share your pain. You start with your family doctor, and you share your pain. And the first question is, how about your family, your mom? Was she dealing with the same pain as well? So we see gender bias in terms of kind of dismissing the symptoms that you as a woman are experiencing, especially when it comes to pain. And the others are mostly related to education. Education on the patient side, education is on the provider side, and basically the lack of patient-provider relationship. Many of our providers are overwhelmed, super busy. Maybe they get 5 minutes, 10 minutes with their patients and answer a couple of questions that they have, but that's it. Another thing that might be helpful is the referral system. 3 steps to get diagnosed with endo. Usually I go to my primary care multiple times, share that I'm in pain, get dismissed. Eventually, I get referred to a gynecologist, and then I share my symptoms. I might get a chance to get a referral from them to an endo specialist if they notice that it might be endometriosis. And when I go to endometriosis specialists, guess what? Most of them, they are endosurgeons. So what they suggest is to, okay, either let me do a surgery on you, which is laparoscopy, which is the golden standard of diagnosis for endometriosis, or you can wait years until you decide that you want to get pregnant. If you face any problems, then come and we talk about the details. So, and then let's say you decide to do a surgery, and post-surgery, you usually don't get referred back to the same gynecologist that you were working with. So this referral system needs more work. Another part that I want to mention is the diagnosis pathway, that we barely see tracking symptoms from patient side religiously, and then or from the provider side. And this creates problem. Nowadays with AI, with technology, with more symptom tracking solutions out there, maybe if we push patients to do more symptom tracking, this might be really helpful to catch those diseases early on. And then continue with non-invasive technologies for non-invasive diagnosis of endometriosis, and with different AI modeling classifications and biomarkers that are out there. There are multiple ways, non-invasive ways to work on early diagnosis. So there are so many things that we should do and we can do.
Great. And so I'm going to keep you going just on AI and what you're doing. Kind of changed it up a little bit, but you touched on the AI. And what do you see, from the early detection with using AI to do that? What do you see as, potential benefits of that, and maybe some guardrails that you need to put on it?
There are two separate conversations. Using AI for early diagnosis and early screening and for the patient care, and post-diagnosis or post-operation, we're talking about continuous care, because endometriosis is one of those conditions that you don't have a solution for. You can, there is no cure, there is no treatment. It's all about symptom management, temporary with hormonal or surgery, but anything you do, it's temporary. When it comes to the diagnosis part, there are solutions that you can use biomarkers, different specific AI models like SVM has been really helpful in early diagnosis. It can be blood-based, saliva-based, vaginal fluids, or so many other things that we see multiple technologies out there. When it comes to the post-diagnosis continuous care, different LLM models can really help to educate those patients. Health agents out there can help with continuous follow-ups with the patients post-diagnosis, and connect the patients through EMR, EHR integrations between patients and providers. That will add a lot of value as well. So, and also another angle is that when it comes to large image processing, so when it comes specifically to endometriosis, many surgeons, they record videos of surgeries because laparoscopy video is included. And almost all of those videos haven't been used for anything advanced right now. So taking those videos, tagging them, and then feeding them to a neural network is like, there are huge amounts of maybe hundreds of thousands of hours of laparoscopy surgery with the best surgeons out there, that this can be helpful for young surgeons that usually don't have time to educate themselves and not even learn from those experienced surgeons. So you use AI to educate young surgeons as well, and also educate patients about their experience and symptoms as well.
Thank you. So, Emily, you talked a little bit about where you've seen some really amazing new things, and I kind of love for you to talk a little bit more about approaches and the use of technology in a different way that will revolutionize pelvic health.
Sure. So like I alluded to, we're finding more and more that there's strong evidence suggesting there's microbial components, even in endometriosis, ovarian cancer, and the like, not just the infection side of the equation, also the chronic inflammation and tissue degradation side of the equation. So there's a lot of new ways to think about how to modulate and control microbial behavior beyond just antibiotics. And it's the case that metronidazole and clindamycin and other antimicrobial agents are first-tier treatments for bacterial vaginosis, or obviously the azole family for yeast infections. But what we're seeing in the ecosystem across the globe is a significant uptick in antimicrobial resistance rates, particularly in women that suffer from recurrent yeast infections, urinary tract infections, and bacterial vaginosis. And so what we've done is really try to go back to the bench and try and find novel approaches to modulate the microbial ecosystem to really stimulate the outgrowth of beneficial flora that we want to inhabit in healthy women, but at the same time also stymie the growth of these harmful, pathogenic, or endogenous strains that tend to outgrow over time and as they ebb and flow throughout stress or hormone fluxes, and really learn how to kind of modulate that ecosystem for the benefit of the woman.
So, fixing from the inside out.
Yeah.
That's the title of our session.
And what we've learned is that also, if you take an outside strain like a probiotic, the reason we don't see clinical benefits is because we're seeing that you actually have to work with a woman's own unique fingerprint of their own microbiome in order to really maximize the potential outcome for her benefits, which is a kind of different approach. And that's one of the aspects that we're really focused on.
Great. Okay, Irene, we touched on a little bit about just the fact that, like PCOS, that women of color are reacting differently, or you're seeing different trends from your research. I'm wondering if you could talk a little bit more about how we could address the stigma of looking at issues from a cultural perspective in your research that you're doing. Sorry.
I think we have issues with, as you mentioned, with stigma just in general with gynecologic health and women's health. And one of the challenges, and I think I was talking about it at lunch with Andy, and because it's something that every woman has, it's seen as a personal issue or a personal problem. Whereas if you develop breast cancer, you're not going to get the same response of figure it out as you would if you had endometriosis or abnormal menstrual bleeding or fibroids. And so I think to really address the stigma in these various disparities, as a researcher, I understand generalizability. You always want data and you want to generalize out. But when it comes to actually implementing the work in the healthcare, you need precision and you need to understand your patient population. And so I bring that up because we talk a lot about social determinants of health, and it's a really nice buzzword. But if transportation is an issue, it is very different for someone in downtown Baltimore, in the city center, to have a transportation issue different from someone in Appalachia, West Virginia, very different from someone in the suburbs of LA. And so, yes, transportation is the issue, but you have to know your population and you have to break down how you can provide care with transportation that is unique to your own. And so I think that's what starts to change the stigma, because it says, I don't just see every woman needing this. I don't just see every African-American woman or every Asian woman. I'm seeing the population that comes into my clinic and the individual that comes into my clinic in figuring out how I can provide them the best care. And so that takes knowledge of your patient population. That takes a different level of education and commitment to being able to solve this problem. But then it also speaks to your patient knowing that they're seen and knowing that their voice, I think drilling down gives voice to those individuals, and that's what starts to shift and change and reduce the stigma that's associated with a lot of these conditions.
Would you say education's a big part of that as well?
Very much so. And in education, and not just the knowledge of it, but actually applying it into the wisdom of how it's important for the person I'm speaking to. It's almost when you give your pitch, right? We know that if we're pitching to an angel investor, it's very different from pitching to a government agency for funding, and it's very different from pitching to, an industry, right? But we don't think about that in the same way when we want to treat. It's very different if you're working with someone who's 50 or 60 or 70 plus, and versus someone who's 18 or 20, you can throw, it's very interesting, the QR codes, right? If you give my mother a QR code, she doesn't know what to do with it. But if you give it to my niece, she would have collected every last QR code on this screen just like that. We don't think about it in those terms.
Yep. Before we open it up to questions, I wanted to ask Mark a question about, we talked about workplace productivity. So with these dealing with these issues silently, it does cause issues at work. And I know you've done some work on, how to help employees dealing with this and helping employers to understand what goes on with that whole having to deal with these types of issues kind of alone, right?
The same way that we have a problem between the patient and the provider, the relationship, educating both of them, same goes with the employer and employee as well. That maybe more education for the employers, for the decision makers, for HR people, for executives and managers can help us to create more inclusive and habitable working environment for all of us. We did a study of 32,000 female employees in the US, and the result shows that average female employee is losing 9 days of absenteeism and 12 days of presenteeism, 96 hours specific, 21 days combined because of pelvic-related problems. And that's happening because of 6 specific symptoms and conditions that most of them they don't get addressed in the workplace, dismissed because of the stigma, because we don't talk about that. So I think when we start educating ourselves as managers, as decision makers, we might get a chance to create that inclusive and, again, habitable working environment. And let me tell you this is not an D&I effort. 57% of workforce are females. It's not a minority play here. It's the top play. And again, it's not a bottom line play. It's a top line. There are many studies out there that shows that the companies that pay attention to this balance, to create that equality and equity in the workplace, they do better financially. More revenue, more profit, because they have been able to create that culture, that nice culture within. To address the part of your question, more options for remote work, more flexibility in terms of the difference between the male and female employees. And one more thing, since 1960s, 1970s, we have come a long way bringing more females, basically bringing more equality to the workplace in terms of numbers, which is great. But when it comes to creating that habitable working environment for all of us, I think we have a long way to go. I think we should acknowledge the biological differences between male and female. Wrongfully, some employers, they are punishing female employees 81 cents on a dollar because they are female, because they get pregnant. But when it comes to offering those benefits, those habitable working environments, they might not consider those biological differences. So I think not only we should have that equal pay, that we have been all talking about that, and some companies are implementing that, but also should consider the biological differences and have those flexibilities, more benefits, more a better culture in the workplace for the female employees.
Great. Okay, so we're going to open up the floor if there are any questions. Then we have one. Yep. Here, I think we have a microphone for you.
Well, my voice carries, but maybe this room is a bit too big. Hi, can you hear me?
Yep.
Hey, Mark, good to see you. So my question is, these challenges and these problems are well known, have been for a while. And I'm literally just coming from another session on the silver tsunami with a bunch of investors. And when asked about market gaps, they talked about everything else under the sky, but yet the products and services that we see coming assume that men and women have same problems, they age the same way, everything is the same. And the reality is, even wearing the business hat, women tend to live longer. Sorry, guys. And the $8 trillion plus that are controlled by 60 plus population, most of them will be handled by women. And on the other end, women between the ages of 42 to 58 are the primary decision makers for not just their families, but for their children, their in-laws, their own parents. And yet we see these huge gaps consistently in the marketplace. What is needed to make that change? Whether it's bone health, whether it's endometriosis, whether it's dementia, what is needed to put the focus back on what a woman needs?
That's a great question. I'm going to start with Emily.
Yeah.
I know you have some thoughts on this.
Yeah. So I think one thing is that women tend not to think of themselves first, right? We are inherent caretakers. We take care of others first and foremost. And I think if we can be a little selfish sometimes, I think that would be good for our own health and thoughtfulness about taking care of ourselves and not just focusing on everybody else in the equation. I definitely also think that from a fundraising perspective, from a marketing and market awareness perspective, I think we could do a heck of a lot better investing in women and really promoting and lifting us all up globally, not just in the United States.
Mark, would you like to?
If I can build on what Emily said, two things. When it comes to investment, 90% of investors are male, unfortunately, and we need to bring more men allies to women's health. As a male leader in a women's health space, one of the key missions that I have is to every week at least talk to 3 decision makers and influencers in corporations and organizations, investors, to educate them or bring more awareness to the community. As President Macron of France said, when it comes to women's health, it's not just women's issues. It's a societal issue because not only it impacts individuals, but their families and their businesses and the whole society as well. So with more investment in women's health and more attention, we can build more vibrant societies. And in order to have more impactful investments, I think paying attention to again, those biological differences and understanding that and acknowledging, not just understanding, acknowledging those differences and education, those are the key things that I think are missing right now.
I think there's one other angle that that was great, by the way. Irene, as far as all the research that's going on, it's making everyone aware of the research. Oh, sorry. The research, I'm very handsy. The research that could help make investors aware of the situation so that it becomes more mainstream. Do you want to speak to that?
Yeah, I would almost say, which might not be popular, but follow me for a second. We don't need equality in it, we need equity. Because equality says the same. 10,000, 10,000. But if you look at conditions that disproportionately affect women, and you're looking at sex as a biological variable or gender, if Alzheimer's disease or autoimmune affects 80% of women, then it's not 50-50 in how you study autoimmune. You have to study it at a greater extent in women to address those disparities. But I say that also because, as you mentioned, we need to commit the money. Kind of how this White House initiative did, it committed the money. The DoD is now saying $500 million, because if you commit it specifically to women's health, if investors say we're going to put 20% of our portfolio, then there is a lot of strong research in that area, but it might not be the same quantity as their competitors. So if you get 100 grants and it's all equal, maybe 10 or 15 will be. So you're going to get, in women, 10 or 15 might be specifically on women's health. So you're not going to notice them as much as the 85 in these other conditions. But if you say we are dedicating this money to women's health, those 20, 10 of them are going to be really strong. So you're not losing your investment. It's not risky at all. It's now allowing them to be lifted to the top, to be able to see and have an equitable chance of competing against the majority number.
Thank you. I think we have one more question, and then we'll have to wrap it up.
Okay, so I always like to be a bit more controversial. So let's understand why we're talking about women's health today, picking up the last lady's question, actually, okay? So 2 years ago at the United Nations Science Summit, Nicole and Irene were part of a panel that we had on women's health. This year at the United Nations Science Summit, we did virtually a whole day on women's health. So picking up one of the answers is that we need to raise awareness. And in the United Kingdom, there is a force of nature who is a UK MP who is co-chair of the UK Menopause Task Force. And she has enlisted the help of about 4 or 5 very famous women who are either television stars, one film star, and one who happens to be the wife of Rod Stewart, who she sets in motion to actually tackle knowledge of the discrimination that takes place. So what we're trying to do in a small way is, one, bring awareness of this, shame people around what's happening to women. But the big challenge I'm going to issue in this room is stick your hand up if you're a man. Come on, guys, stick your hands up. Okay. Every one of you has a mother. Most of you might have a sister. Pretty much most of us have a wife or a girlfriend. And some of us have daughters. Why the hell aren't we interested in this subject? We have every reason to do this. What we need to do as men is actually be part of the solution and not leave this to women to be championing things. So it's great to see Mark on the panel getting involved in women's issues. So what we're looking for is anybody who has an interest in this subject to actually speak to the panelists, get involved, be part of the solution, because this is too important just to leave to politicians over time. Thank you.
That's a mic drop right there. Great. Well, unfortunately, we're going to have to wrap up our session. Thank you so much to our panelists. I thought we had some great insight, and if you'd like to speak with them, they'll be around after our whole session, as I will too. And thank you very much. And I will now bring up John Warner, and we can talk about healthy aging.